We're going to start with a really happy slide, okay, just to give you an idea of what happens. This is a map that shows us basically how we die, so let's keep it happy, shall we? At the bottom here, this is 0 and it goes up to 95, and you can see there's a whole group of ages as we go up here. And up here on the y-axis is the reason we die. So if you look, for example, at, I'm just going to get this dot here, the blue, that means that's a road traffic collision. If you look at the green, then that means that's an other accident. If we look at, sadly, other conditions, this sort of yellowy colour here, that's suicide, which sadly is out there and it's a real problem for us. And then other unnatural deaths is this slightly smaller blue colour, and that's often drug related. So people, who, for example, who have overdosed or perhaps taken heroin, that type of thing. Then above that we've got the blue colour, the sort of purple colour, that's cancer. Then we've got heart disease, which is this sort of pinky colour, and then we've got an other. And as you will see very clearly, sadly, trauma is a disease that very much affects the under 40s, okay? It's very rare that you see a 95-year-old handbrake turning around the car park in Hedge End. I think we'd all agree. And when you reach that age, you're more mature, you realise the risks and everything else. But if you ever go to Hedge End Currys or Hedge End Sainsbury's on a Saturday night, you will see people handbrake turning around there. They're generally young and they don't realise the risks that they're doing. But the whole point of this slide is to show you that the real risk here for people dying of trauma is in the under 40s, and it's really, really important that we recognise that. As we get older, sadly, we die of other things such as cancer, heart disease, and all those other things. So that's the depressing slide over and done with. Okay, we'll move on from now. The only way is up. I like to say. This is a map that shows you road traffic collisions where people have been killed, and records were first kept in 1926, which I find staggering. I don't think anyone in the room will remember 1926, maybe Rob? But in 1926, 5,000 people a year were dying on the roads of Great Britain, quite a staggering number. We saw some massive peaks in 1940 and 1941, which is obviously during wartime years. That was the biggest peak ever, and that relates to probably two things. First of all, who was in the country? Young, fit, healthy people who took risks, soldiers, for example. So we know they're a high-risk group, but also things like the blackout. So the blackout, where people were encouraged to put slit lamps over their lights, they were turning all the lights off. It made it much more difficult and dangerous for everyone. And then gradually what we've seen is this very good picture as deaths gradually drop off. And last year, tragically, 1,780 people died on the roads of Great Britain. That has actually gone up by 10 compared to the last previous year. Lots of reasons for that, but the overall picture is generally very good. But what we must never, ever lose sight of is behind every single one of those road deaths is an utter tragedy for a family, for work colleagues, for friends, and everyone else. And I always say to our crews, they must always have that in the back of their mind. It's vital that we remember that behind every one of those statistics is an utter tragedy for someone. We've seen this good reduction, and that's generally as a result of, for example, better medical care, so people getting looked after better, road design, so for example having roundabouts instead of T-junctions, road vehicle design, so airbags, seat belts, drink driving campaigns. All these campaigns have added up together to bring our road deaths down. But as we say, we mustn't be complacent because we've actually gone up by 10 in the last year. But it isn't all about road traffic collisions. We're talking about major trauma today, and we always think that's about road accidents, but there's a whole lot of other things there. So in SCAS, this area here, we go to a lot of patients who have fallen. So we often think that just a standard fall from less than 2 meters, literally a fall from standing height, isn't going to hurt us. It does. About 40% of all major trauma that goes into Southampton is as a result of falling less than 2 meters. So this is a significant risk, particularly the type of people that fall over are older. They often have comorbidities. They're often on things like blood thinners, which makes them much more prone to complications. Falls of greater than 2 meters, there are 3 groups that we see in there. We sometimes see it in children during hot months where they fall out of windows. We see it sadly in people that throw themselves off, for example, the Itchen Bridge, which is quite a common one. And we often see industrial incidents as well, so where people are working at height, perhaps not well protected, and then they fall. Suspension trauma is a polite way of saying hanging, and sadly we do see a lot of hangings in our patch. I personally went to 3 in one day. That gives you an example of just how bad it can be. We tend to see lots of pockets around prisons. There's a lot of that problem in prisons, but generally it can happen absolutely anywhere. Penetrating trauma, there's a lot of this in the press. Many of you will be aware about knife crime. Thankfully, here in our area, we're actually relatively safe. Okay, I want to reassure everybody about that. We don't get that much knife crime, but we have got pockets of quite high levels. And obviously, we're doing some work to try and reduce that. So we're now working with what we call our violence reduction units, which have been started by the police commissioners to try and drive down trauma. And what we're doing is we're now able to map where people are getting stabbed, what age groups, what time of day, what area. So obviously by doing that, we can potentially do some prevention work, which is great. Burns injury is significant. So burns, we go to quite a lot of burns, and the peak age group for burns are actually the 0 to 4-year-olds. This is often where they pull down cups of tea, kettles, that type of thing on themselves. So that's our peak age group. Occupational injuries is things like people at work. So we do go to people, chimney sweeps, that type of thing. And sports injuries, we should never forget. Does anyone ride horses here? No, good answer, because they smelly, horrible things and very expensive as well. But we go to a lot of horse riding incidents. I personally, just in the last week, have done 2. People who either fall off of horses or get rolled on by them. I don't know why anyone would ever have a horse, but there you go. In terms of major trauma, there's about 20,000 cases of major trauma in England alone. And in our SCAS patch, so we are a large trust. People often think we just cover Southampton or we just cover Winchester, but we don't. We go all the way up to Milton Keynes, across to Banbury, and then down to the seaside. So it's a really, really significant patch. And within that, we see about 5.4 patients per day with major trauma. So thankfully, it's relatively rare. The good thing is that means that we don't go to it too often. But in a way, that's bad, because if our crews aren't going to on a regular basis, then potentially they can de-skill. And this is why we've seen the proliferation of air ambulances, who give us a vital bit of support, where they go out and they've got critical care paramedics who go to these sorts of jobs every single day. Of those, about 5,400 deaths will occur. So as we can see, 1 in 3 relate to road accidents. The other 2/3 are all the other things that we've discussed earlier. And in terms of cost, this costs us as an organisation, as a country, an absolute fortune. This is Department of Health's own figures, that if a 25-year-old is killed in a road accident, it costs us as taxpayers £1.6 million per case. Now you may go, well, I know that Professor Crouch is really expensive, but that's not where the money is. What we do is we invest very, very heavily in our young. So we make sure they're well educated, they're in good health, and they basically go on to work. And by doing that, we then know that we're going to get repaid with taxes, okay? So the way this is calculated, if somebody's life is snubbed out at the age of 25, there'll be no return coming back, but we've invested very heavily. And sadly, it's a huge amount of money. And anything we can do in terms of prevention to try and prevent just a few of these obviously makes a lot of economic sense, plus all the other welfare issues for families, etc. But what is major trauma? So this is a pie chart showing you major trauma, and it's thankfully rare. This is the red part here. These patients are critically ill. If they don't get immediate care, they are likely to die. And they have what we call an injury severity score of greater than 15. Sounds really confusing, and it is, because it's calculated in hospital, not at the side of the road. There's no way you can do that. These are typically complex, typically multi-system injuries, so broken femurs and a head injury and a chest injury, those type of injuries. The yellow group, which we see there, are still serious injuries. So yellow group just there, as you can see. These patients have got a lower score, what we call an injury severity score of 9 to 15. They're still serious, and particularly in the over 75s, they can be fatal. Okay, so it's really dangerous, but most youngsters with a score of 9 to 15 will survive and make a full recovery. And thankfully, the vast majority of what we go to isn't major and isn't serious. These are patients who have fallen over, broken their arm or broken their leg, but no other injuries as well. And thankfully, that's the vast majority of what we go. This is a real patient. This patient was actually hit in Southampton by a bus. I went to them. This is the way it's calculated. And there's no way you're going to remember this, guys. Okay, so you don't need to. There's no quiz or exam at the end of this. But what we've done here, this patient had a cerebral contusion, which means they had a bleed on their brain. They also had a flailed chest, which is where you get multiple rib fractures on one side, and they also had a fractured femur. And in hospital, not at the side of the road, what they do is they calculate this accident injury severity score. They then square it and add up your 3 worst injuries. Now, You don't need to remember that, but this patient scores 34. And by definition, what we've said is if a patient scores 15 or more, they're likely to die as a result of trauma. And so this patient, by definition, has major trauma. They're going to need intensive care, they'll need air ambulances, they'll need all the other bits and pieces that go with it. So hopefully that gives you an idea of how it's calculated. But as you can see, that's done in hospital. There's no way at the side of the road, we don't have x-rays, we don't have CT scans, so it's really, really challenging to identify those patients that are really seriously hurt. And I know you can't see the detail on here, but this is what's called the TUB tool, the Trauma Unit Bypass tool. If we go to a patient with these type of injuries, and I'll show you what I mean by that in the next couple of slides, then the principle is that these patients are taken straight to a major trauma centre, which is where they get the best possible care. What we've done using our SCAS charity money is we've paid for an app as well, which is fantastic. If anyone wants to see it, I'm happy to show it at the end. But it's an app and you basically press on it and it tells you whether you should go to a major trauma centre. It even maps what entrance to go to, what the pre-alert numbers are, all those other things, which for our crews is an absolute boon. The principle is that all patients with major trauma are going to be conveyed straight to the major trauma centres. And in our patch, we've got one in Southampton and one in Oxford. But there are obviously going to be exceptions. If you're in Newbury with somebody that's been hit by a car and they are too sick to travel, we're going to go to the nearest hospital. If they're just too unwell, we don't want to put someone in the back of the ambulance for them to deteriorate and sadly even die on the way. We're not going to do that. So we're going to take the stable patients but who are critically injured directly to the major trauma centres. The exceptions there are patient with catastrophic hemorrhage. So if someone, for example, is hosing out blood and we can't stop that at the scene, we've got loads of good equipment to do that. But if we truly can't stop it, then we'll go to the nearest hospital where they'll be stabilised. It's the same for an airway problem. So if we go to someone, for example, that's been in a house fire and we can't manage the airway, we'll go to the local hospital and then they'll stabilise them. And then usually we'll transfer them down to the major trauma centre. An imminent cardiac arrest, so sadly some trauma jobs you go to, they're taking their last breaths. There's no way we want to run 40 minutes, 50 minutes down across the truss. We're going to go to the nearest hospital, the patient will be stabilised and then transferred from there. So this is a map that shows you how the trauma network works, and we're obviously this patch here. This is Oxford and this is Southampton down here. So we have major trauma centres here, and this is ideally where our seriously injured cases are going to be taken. We've also got what are called trauma units. So they're the second tier down. It doesn't mean their staff are worse than those in the major trauma centre. They're still fantastic staff. It's just they're not set up to deal with major trauma. So these are trauma units. And basically what happens is if patients are fine and they're not seriously injured, then patients will continue to be taken to trauma units. If they're seriously hurt, our crews will actually bypass those trauma units and go straight to the major trauma centre. And you can imagine that's quite a tense time in the back of an ambulance, driving past the front door of a hospital to go straight to the major trauma centre. And we've got a third tier of hospitals, what we call our local receiving hospitals. You sometimes hear them referred to as local emergency hospitals, places currently like Bournemouth, which is going to change, and also places like Winchester, which are currently the third tier. And again, they offer a fantastic service to patients, but they are not set up to deal with patients with major trauma. So spotting the sickest cases for us, because we can't score, well, what we have is a trauma unit bypass tool, and the clues that give us an idea that somebody's critically injured is if they've got a respiratory rate of less than 10 or greater than 29. Most of us in this room are probably breathing somewhere between 12 and 20 breaths a minute. That would be a normal sort of respiratory rate. If somebody's critically hurt and they're bleeding, they will be breathing an awful lot faster than that. And we often go to patients with, for example, who are really sick, who have got respiratory rates of 50 or 60. And if we go to a trauma case and they've got a respiratory rate of 60, they're going to go straight to the major trauma centre. We look at blood pressure. So what we'll do is we'll check their blood pressure, and we can do that really quickly. Just by feeling someone's pulse gives you a really good clue. If you can feel a pulse that their blood pressure is greater than 90. So this doesn't take long to do. It's a very quick test, and if they've got a decent blood pressure, then that's a good sign. If they haven't got a radial pulse and they've been involved in trauma, that is a very worrying sign. It's usually a suggestion that they're bleeding, and so for that reason, they will go straight to the major trauma centre. And finally, we use a thing called the Glasgow Coma Score, which is a way of measuring consciousness. So it's a score between 3 and 15, and depending on how alert someone is, if you are fully alert, like hopefully I am, then I've got a Glasgow Coma Score of 15, and someone who's dead is at the bottom end of that with a score of 3. There's a whole spectrum in between. And with us, what we do is we measure one of those components, the motor score, and if a patient is not able, for example, to squeeze our fingers and pull us towards, or not sort of reacting to any pain, then they're going to go straight to the major trauma centre if they've been involved in trauma. The next part that we look for on our trauma unit bypass tool is around injuries. So an open pneumothorax is where you've got air basically escaping and you get that hissing noise. For anyone who's done first aid courses, you probably remember you were taught to tape a credit card down on 3 sides. The reality is, even in 32 years, I think I can honestly say I've only seen probably 5 open pneumothoraxes. They're very, very rare. They're generally caused by penetrating injuries, so such as a knife wound. But a flailed chest is much more common. This is a classic injury where, for example, you're driving your car, often without a seatbelt, and you get hit with blunt trauma. And what they end up with is multiple rib fractures, but not just in one place, in another place as well. And that means at the side of the chest. And the only management for these patients is to go to a major trauma centre, because they do some real expert stuff to make sure that those patients get wired. So they basically fix the ribs. And that means that that patient doesn't then, for example, have to stay on intensive care for months and months. They get weaned off very, very quickly. And they make an amazing recovery. And in terms of pain, that's good. Crushed, degloved or mangled limbs, so that's pretty nasty. If we go to a patient and they've got that, then basically what will happen is they'll go straight to the major trauma centre. Often that's where perhaps people are being crushed by vehicles, rollers, that type of thing. Suspected major pelvic fracture. Well, pelvic fractures are very dangerous. We know that about 38% of people with a low blood pressure with a fractured pelvis will die as a result of that. It's a very dangerous injury. This is a classic horse riding accident that we go to, where horses roll on people. But we see it in motorcyclists, and we often see it in car drivers where they've been T-boned, so they've been hit from the side. And if we go to someone who we suspect has got a major pelvic fracture, they're going to go straight to Southampton or to Oxford. They're going to go to the major trauma centres. Neck or back injury with paralysis is on there, so if somebody's got neck pain and they're unable to move their limbs, the best place for them to go is access to spinal surgeons. And our spinal surgeons are, of course, in our major trauma centres, which is why they're taken there. And I have lost count of the amount of patients who I've been to them and they have nothing from, for example, here down, and actually have gone on to make an incredibly good recovery, which is always good. And that's because they get expert care in the major trauma centres. This is really confusing. Greater than 1 fractured proximal long bone. We have long bones here, so the humeruses and the femurs. If someone's got more than 1, so they've got 2, that's a really dangerous mechanism. And we often see this in car accidents where the dashboard comes in and people break both of their femurs. And when that happens, that's a very dangerous injury. Not only do you get a lot of blood loss, but it usually indicates that there's lots of other things going on. My femur's about that thick, and you couldn't just break it. It takes a lot of energy. So by definition, usually people are very seriously hurt. Amputated limbs, even I can spot those, so they're pretty, but obviously we take those to where they can manage them. And not very long ago, I went to a gentleman who was working with a guillotine. His colleague didn't speak the same language as him, and you kind of know where this is going. He had both of his arms cut off at about that level. He's done amazingly. They showed his video at the last trauma conference. He's able to open jars, he's able to work, he's able to feel, and they reimplanted them, and that's because they had expertise, plastic surgeons available who were able to do that. It's incredible how good they are. Amputated limbs we've covered, but suspected open or depressed skull fractures. If somebody's got a depressed skull fracture, this is often caused by blunt trauma, then that's a direct trigger. So if we go to a patient who's got really nasty head injuries, they just go straight to the major trauma centre if they're well enough to go. So I'm going to give you a scenario. You're driving home when you see a motorcyclist lying motionless in the road next to his bike. There are members of the public gathered around, but no emergency services at the scene yet. What should you do? Now, very interestingly, I was in exactly this scenario at 11:30 last night. Having done a very long day, I was going home, and there I saw the hazard lights, and there was a motorcyclist lying. And I wrote this presentation a couple of weeks ago, so I thought, well, that's weird. I'm presenting on that tomorrow. So let's talk about some of the things that you, as members of the public, should consider doing. First of all, we need to think about scene safety. One of the most dangerous places to be, even with blue lights and a fluorescent jacket, is in the road. Okay, people have, has everyone heard of the phrase rubbernecking? We see it, don't we? People have a morbid fascination with, oh, what's going on over there? And when you look towards something, you steer towards it. And so for that reason, your safety is paramount over anything else, even the casualty lying in the road. And you always have to put yourself first. I've been to so many people that are road workers, emergency workers, police, etc., who have had everything going, the blue lights and everything, and yet they've been critically injured as a result of being hit. So we're not immune, and it's a very dangerous place to be. Call for help with accurate information. That's really, really useful for us. So if you call 999, if you were to give us the junction of so if you said I'm at the junction of Winchester Road and Burgess Road, I know where you are within a metre. I can actually plot to put the ambulance there. If you are in a really rural area, such as in the middle of a field, we do have a process called triangulation, which is where when you're on your mobile, we look at the strength of the signal and we can work out roughly within 200 metres where you are. But the ideal, because most accidents happen at junctions, everyone agree with me? About 80% of them do. Well, that's obviously ideal. So give us a location and then we know exactly where to send the ambulance. People often ask me what type of equipment to carry. What should I have in the car? So I'm telling you, you don't need a defib and you certainly don't need a full resuscitation kit. Okay, you definitely don't need all of that. And what I would suggest people have is a mobile phone. That's one of the most useful things to have. Perhaps a fluorescent jacket. That's really useful. Just keep it in the boot in case. A pair of gloves, just in case you're going to get blood on you. And often we suggest an airway adjunct. So just something like a pocket mask. And that's all you need. Don't carry lots of stuff. It's the simple things that make a difference here. It really is. And what we always tell members of the public is to only do the basics, but often the basics are the most important thing to do. About 20% of people that die as a result of trauma die of things that can be reversed, that potentially they have just got an airway occlusion, and actually a simple first aid measure may be enough to save their life. So things like airway, so keeping someone's airway open. We're obviously not going to move someone's neck too much, but obviously airway does take priority. If my airway is occluded, it is 100% certain that I'm going to die as a result of that. And simple airway measures, opening my airway, can be life-saving. Never underestimate keeping people warm. That's really impressive. When we get cold, our clotting is really badly affected by that, and we can bleed and bleed and bleed, and our bleeding doesn't stop. But if we keep people warm just by chucking a few coats over them and a few blankets, that makes a massive difference to patients. And this is something that we're really pushing to our crews. So if we go to a trauma case, we'll put it onto the Barbados setting in the back of the ambulance, which is literally full blast heat. And that's because we know that even in Afghanistan, the soldiers who are injured in really high heat, they still come into Camp Bastion, they come into hospital hypothermic, and that's because they're losing blood. So we always try and keep our patients as warm as possible. And what we do want to do is to try and keep these patients as still as possible. We want minimal movement. Moving people around can be dangerous. It can exacerbate and increase their pain as well. So for that reason, we try and keep people as still as possible. And if anyone hasn't done a first aid course, really recommend to do that. It gives you that confidence, whether it's CPR, whatever it is, to go out and actually do it. We really do recommend that you do a basic first aid course. This is something they're going to be teaching in schools, and I absolutely applaud that. So for young kids, they're going to be getting, as part of their curriculum, basic life support, which absolutely should be out there, and that's really good. And they've done that in some countries, Sweden, for example, and they've actually managed to double their resuscitation rates for survival by doing that, by teaching kids. So when you phone 999, to assess the urgency, we use a software called NHS Pathways, which is our triage system that they use in the control room. Our two control rooms, we've got one in Otterbourne, which is near Winchester, and one in Bicester. And if one of our control rooms is really, really busy, it doesn't matter because the other unit will take the calls, so it doesn't matter where you are. And basically what happens is we then put your call through a triage algorithm, which is why you're asked, is the patient bleeding, are they breathing, all those type of things. And basically what then happens is we come up with a decision as to what to send you. Some people will phone 999 for nothing. I'm writing a book on it at this very minute in time. People will phone up saying, I've had toothache for the last 3 months, give me an ambulance now. And then we get the other extreme where people really don't want to bother us. But we would always say if people have got chest pain or they see an accident, we never mind being bothered for those instances. We want to know about it, okay? The worst thing is when we go to someone who's had a heart attack 8 hours ago and it kind of gets a bit late to do anything about it. So never feel guilty about calling 999 if it's for an appropriate cause. When we have triaged the calls, they basically drop into one of 4 groups. We've got category 1 calls, category 2 calls, category 3 calls, and category 4 calls. Category 1s are our most urgent level of response. And I have very deliberately put a picture of a trump card. Does everyone remember trump cards? The trump card of the car world apparently is a Toyota Prius. Okay? It's the most reliable, it hardly ever breaks down, it uses hardly any fuel, all the other bits and pieces. It's a great, great car to have, apparently, not that I'd have one. And our Toyota Prius, our trump card, is the category 1 call. If we are going to somebody who's in a lower category and a cardiac arrest, for example, comes out, we will divert that ambulance to go to the higher category. They're very rare calls, only about 5% of our workload, but they are significant. We know there's an immediate threat to life, things like choking, drowning, cardiac arrest, people who are fitting, those type of things. Those are immediate emergencies. And major trauma will sit in the 18-minute, but obviously if someone's critically hurt and, for example, they're not managing their airway, then they will sit in the category 1 7-minute response. But the vast majority of our trauma cases will sit in that 18-minute response time. When our crews arrive, they will perform a quick assessment, and that's not just an assessment of the patient. So when we arrive on scene, we're thinking about reporting back to our control room. What's our exact location? Really important they know that. What's the type of incident? Is it a road crash? What is it? The hazards. So there might be hazards. You might have fast moving traffic going past the scene. You might have an assailant still at scene if it's an assault, those type of things. We're thinking about access. So what's the best route in? What's the best route out? When I need my crew to come and back me up, what's the best route in for them? You're always thinking like that. And then you're also thinking about the number of casualties. So how many casualties and how severely injured are they? And then the last thing I'm going to be thinking is the emergency services. Who's here now and who do I need to come to the scene to give me a hand? We'll be reporting all of that almost straight away when we get to the scene. It's really important we do that so that we can ensure, and sometimes it's things like the air ambulances that can make a massive difference. At this point, they'll probably come and ask you, did you see what happened? And it's really useful if you did see an accident or if you did see somebody getting injured, let us know what you saw. That's really useful for us. I saw he was unconscious for 2 or 3 minutes, but he's woken up now. That's so vital. You will know about ABC, airway, breathing, circulation. It's sort of first aid and it's been taught for quite a few years. But in trauma, we use it slightly differently. We've put a big C in front here, and that stands for catastrophic hemorrhage. So what the principle here is we will deal with catastrophic hemorrhage. So if someone's got a leg hanging off and we have to put a tourniquet on, we'll deal with that before we do anything about airway, breathing, circulation, or anything else at all. And this is the structure that we use when we're out on the road. The airway, we'll obviously be thinking about opening the airway and making sure that patients have got lots of oxygen. But the other thing we're going to be considering is the neck as well, because sometimes patients who have been hit by a car, for example, will have a broken neck. Then we'll move on to breathing and we'll be looking at the patient's chest, we'll be listening to the chest, we'll be doing all sorts of bits and pieces. Before we then move on to circulation, which is where we might think about putting a cannula in the patient, thinking about some pain relief, all those type of things. And then we move on to disability, which is where we're moving on to how awake they are, before we then move to E, which is where we expose, and E stands for exposure. So it's a really rigid structure. It came from the military, and all the good things that have come into healthcare have come from the military. They've learnt this over years, and basically that's the structure that we use, and it's exactly the same as you'd use anywhere in the Western world, or in the military arena, or anything like that. So the patient will be stabilised at the scene. So treatment of blood loss will obviously stop blood loss. That's one of the things. But we do actually have really amazing medicines that stop bleeding. So we use a drug called tranexamic acid, which is given into patients' veins. We give it, and basically what that does is stop the clots from breaking down, which is great. And that can buy you time to get these patients to the major trauma centre, especially when, for example, you're travelling from Basingstoke all the way down to Southampton. Stabilisation of injuries, so this is often, for example, splintage, so we'll be able to put splints on these patients. Pain relief, so we can use things like intravenous paracetamol. I thought intravenous paracetamol was a bit homeopathic, a bit like chewing a tea bag and running around 8 times, but actually, intravenously, it's amazing, and it's as effective as morphine in many cases, but we do use morphine as well, and we've got other stronger medicines as well. For Jack and I, we carry ketamine, which is a really useful medicine for patients who have really serious fractures and dislocations. And involvement of the air ambulances. So we're very fortunate to have 2 air ambulances in our patch. We've got Helimed 56, which is based down here near Thruxton, and they will fly anywhere. They can get pretty much anywhere within a 12-minute window around Hampshire. And for the north of our patch, we've got an air ambulance based at RAF Benson, Helimed 24. So they're based up in Benson. And again, they tend to cover the north, but at night, we always have one air ambulance on duty, and they can go north or south. It really doesn't matter at all. And what generally, we have a doctor and a paramedic, or sometimes two paramedics on the aircraft. And during busy times, we put them on cars as well. So some of the mapping that we've done, they'll sit in cars, and that's particularly useful for urban areas where it's very difficult to land, particularly at night. And then what they'll do is they'll transport the patient to hospital. And what we do is we pass a pre-alert call, which is where we'll phone Rob and say, hi, we've got a patient for you. That means that they can prepare, and Rob's going to tell you a little bit about the type of reception we get when we arrive. When we're handing over the patient at hospital, in fact, if the air ambulance arrives, we use what's called ATMIST, which is a really easy way to remember it. Most of us have it on laminated cards in our never-ending pockets. The age of the patient, the time that the incident occurred, the mechanism of injury, so they might have been hit by a car or stabbed or whatever, the injuries that we've managed to find, the signs, so that's usually the blood pressure, and T is the treatment that we've done. It's a really nice structure, and we often write it down before we even get there, because when we get to the resus room, there's like 25 people all waiting to hear, and it's quite a nerve-wracking experience, so we'll write it all down, and when we arrive in the resus room, that's basically what, that's the structure that we use. And this is used entirely across the Western world. Doesn't matter if you're in Australia, they'll use ATMIST as well. And if we go to the resus room, for example, at Southampton or any of our hospitals, they have ATMIST written down, and when we phone through, they'll write it down next to the relevant field. And finally, one of my ambitions was to make you drive more safely, wasn't it? Okay. So this is a map showing you where all road traffic collisions happen within a 1-year period within our South Central patch. So by definition, patients have been injured. The really good news for anyone who's driving back up the A34 is that there is a safe spot just here where you can do 100 miles an hour. But the problem is you'll then hit the back of another blob and you'll become one of those statistics, okay? So you can very clearly see that our road networks, that's the A34. You can see that we've got some areas around Slough, which are quite high risk, Milton Keynes as well. This area around here, this is Southampton, this is Portsmouth. It's even known as the dumbbell of death, okay? This is an awful area for trauma. You can see we get an awful lot of accidents. It's been found to be one of the worst areas for tailgating in the entire UK. It's got some shocking driving standards on there. Hopefully now it's down to 50 miles an hour, that will help. But you can see we get a lot of accidents there, and that's one of the reasons why our air ambulance car now sits at Whiteley Village. Perfect place to go. And you'll see them, they'll be in Costa Coffee, because that's what they do. They call it a code Charlie Charlie, which is where they sit waiting for a job. But you can see why they're placed there, because it makes an awful lot of sense. But we can break our data down even better than that. This data's all come from our electronic patient records. So if we wanted to, are there any motorcyclists in the room? No one's going to admit to that now, are they? That's cool. Here are motorcycles. So you can see, again, we've got big pockets around here. The bigger the blob, the bigger the problem. Can everyone see this big blob here? Does anyone want to have a guess what that might be? Perfect. That is Lumi's Cafe. That's where all the bikers meet up. Okay, that is exactly where it is. So you can see here we have a really big blob, and sadly we've had 9 killed or seriously injured within that area very recently. That's where all the bikers meet up. Bit of bravado, and they go racing around there, and sadly it ends in bad consequences. But again, you can see it scattered. So you can see how potentially for prevention, that would be really, really useful. If we know what time of the day it's happening, etc., that's really good. And finally, I'd like to show you the day of the week. So the good news today, I've got some good news. On the bottom here, this is midnight. This is 7 and 8 and 9 o'clock. This is in the evening, so this is 4, 5 and 6 o'clock. So the first thing you're going to see is when we see most of our road accidents is during commuter times, rush hour. Can everyone see that really clearly? And the good news is today is Wednesday, isn't it? Yeah, so you've managed to survive today, because the most highest peak for road accidents is actually 8 o'clock in the morning on a Wednesday. I have absolutely no idea why that is, but across our patch, that's the highest risk. The good news is that we've looked at the injury severity scores on these patients, and they're very, very low. These are relatively unscathed. They will have injuries by definition because we've been called, but they're very, very low numbers, okay? So that's good news. In terms of severe injuries, we don't see that. But what I would like to show you is the purple line. The purple line here is Fridays. Can everyone see that quite clearly? So Fridays are by far the worst for major trauma. And just a few weeks ago, we had 3 fatal accidents within 45 minutes of each other on a Friday afternoon. I personally went to 6 fatal accidents in 5 weeks consecutively. So that's how bad it is. Lots of reasons for that. We think that Fridays there is an element of fatigue. We also think there's an element of speeding. So people leave in staggered journeys. Rather than everyone leaving work at 5 o'clock, people will try and get out of work a bit early, which by definition means the roads are quieter, although it doesn't feel like that. So the speeds are higher, plus they're in a rush. Add those 3 factors in together, you end up with an utter catastrophe, and you end up going to the major trauma centre. So please be safe. Okay, everyone, I like to think it changes my behaviour. On a Friday, I'm a completely different driver to what I am. My motto is normally, drive quite quick, but I'm really slow on a Friday, okay? And that's for good reason, because I kind of see the consequences pretty much every single week. And that's it.